It's a 42-year-old female with diabetes type 2, dyslipidemia, and recent emotional stress presented with palpitation with non-specific STT changes in inferior leads on EKG. Her TMT was inconclusive. Her LV ejection fraction on echo is 65% with no regional wall motion abnormality at rest, with grade 1 MVP. She had one episode of syncope 2 years back, which was ascribed as vasovagal shock by her physician. She has family history of sudden cardiac death, elder sister, mother in their 50s. Her 48 Holter revealed 3% of BPC burden without any significant pause. The best non-invasive strategy for her evaluation rather than invasive coronary angiography would be. So it's between cardiac MRI versus CT-CAG. I would like to invite Dr. Purvi to have her opinion.
Hello, has Purvi joined? Can we have her Zoom link live now? Dr. Purvi Parwani is joining us from USA. She's an associate professor, medicine and director of ACO and imaging lab. She's a big figure, always been there with us from the first Cardiocon. Dr. Purvi Parwani is to speak for a role of cardiac MRI in this patient. We have a panel. Dr. Komal herself has been involved.
A very good morning, everyone. I am delighted to be here, and I thank the organizers for invitation again this year. And I will be speaking about diagnostics and the women in cardiology session. These are my disclosures, and this is a case that's been given to me. So we have a 42-year-old female. She has history of type 2 diabetes, hyperlipidemia. Some recent stress comes with palpitation. Her treadmill test is inconclusive due to poor effort tolerance. LVEF is 65% with no regional wall motion abnormalities and grade 1 mitral valve prolapse. She has had a history of syncope 2 years ago. It's considered as vasovagal syncope. Has family history of sudden cardiac death in her elder sister and mother. 48-hour Holter shows 3% PVC burden. And the question is, what is the best non-invasive strategy for her symptom evaluation? And I'm somehow perplexed by why even rather than invasive angiogram term is utilized, but nonetheless, I'll be speaking in favor of cardiac MRI. So, and in favor of cardiac MRI to evaluate arrhythmia, ischemia, as well as structural abnormalities. And I'm sorry, Pooja, but this is a very, very easy debate because of what all CMR can do. But I think let me make a case for why CMR is the modality of choice in this case. So we have let's look at the details. So we have a lady who's 42-year-old. She has past medical history of type 2 diabetes, hyperlipidemia, and some stress. She has very strong family history of sudden cardiac death in the first degree relative, her sister as well as her mom, and she has symptoms of palpitation, history of syncope that is considered as vasovagal syncope, and none of the non-invasive testing so far has been very conclusive, but she does have 3% PVC burden. So the question is, what is the best imaging modality? And I think what we need to think about is what exactly is the reason why she's having palpitation. How are we going to evaluate her high-risk family history situation, and how are we going to give her the sudden cardiac death risk? What is the relevance of EKG and echo findings, which are told to us that they're non-specific? how diagnostic modality can help us, what is the next step is management, and finally, what's the overall prognosis. So I think when we look at the best imaging modality, I think not only best imaging modality needs to be appropriate, but also accurate, efficacious, safe, should have management as well as prognostic implications, and finally should be cost effective. So you want to choose a modality that kind of can answer all these questions that I asked in hopefully in one test, if not more than one. If we look at the reasons for sudden cardiac death, which is probably the most important thing that we need to evaluate for this patient, this is a paper that kind of focused on sudden cardiac death worldwide. What is the demographic situation? And you can see that coronary artery disease makes the most of the etiology of sudden cardiac death, followed by cardiomyopathy, arrhythmias, valvular heart disease, and other reasons. Now, what is what is not very apparent in this coronary artery disease is perhaps when you consider the family history that's been given to us, probably the pendulum here shifts towards the cardiomyopathy and what may be happening with the structural heart disease in this woman's heart. So I think if we look at her palpitation, we of course have to make sure she does not have arrhythmias and cardiomyopathy. If we look at her EKG, which is STT changes, and she has some risk factors like diabetes mellitus, hypertension, we absolutely should look at CAD. Although palpitation is not the symptom of CAD, perhaps we can look at it because she has this premature family history. If we look at her echo and the history that has been given to us with mitral valve prolapse, I think we need to evaluate all the conditions that are associated with mitral valve prolapse, mainly the mitral annular disjunction and the degree of MR on the imaging modality. If we look at syncope as one of the symptoms, then again, we need to evaluate all the structural heart changes, right? So we need to exclude cardiomyopathy, hypertrophic cardiomyopathy, and other cardiomyopathy. And then finally, the similar situation when we look at the sudden cardiac death disease risk in her family. So overall, what I'm trying to tell you is we need to evaluate her ejection fraction very accurately. We need to make sure that there are no structural changes in the myocardium. We need to make sure there is no scar burden in the myocardium. And finally, we need to figure out how are we going to evaluate the coronary artery disease. So if we take all of these things, cardiac MRI can be the one-stop shop. And why that is what we are going to discuss in next few steps. So just for everyone to remember, cardiac MRI is a great tool for the tissue characterization. And what that means is in cardiac MRI, we can give the contrast, and then finally the tissue that is abnormal will light up. And in a patient with PVC, the main concern would be if there is any structural heart damage, that tissue would fire and would be responsible for arrhythmia. So let's look at one by one. So of course, we know that for ejection fraction assessment for both LV as well as the right ventricular ejection fraction, cardiac MRI remains the gold standard. And why that is because we can divide the myocardium into multiple short axes, both on LV and RV side, and we can accurately assess what the ejection fraction is for any particular patient. Similarly, cardiac MRI is very sensitive in detecting the structural heart issues. And I'm not going to go into detail, but in general, I'll show you some examples. So this is an example of a arrhythmogenic cardiomyopathy. This is a left-sided arrhythmogenic cardiomyopathy. You can see the scar all around the myocardium, also in the center of the myocardium, all the way going to the epicardium. You can evaluate the presence of hypertrophic cardiomyopathy. So this is a case with hypertrophic cardiomyopathy with quite a bit of scar everywhere in the myocardium that has been associated with sudden cardiac death risk. We can also evaluate something like sarcoidosis. Sarcoid has been associated with PVC as well as VT. So you can see that in this echo, you can see basal septum that looks quite thinned and aneurysmal, and you can see the scar on the MRI in the similar area. You can also see figure out if there is any dilated cardiomyopathy, and why that is important is because dilated cardiomyopathy again has been associated with scar in the septum, and scar in the septum has been associated with worse outcomes given the risk of ventricular tachycardia or PVC. Finally, we have been given a history that this patient has mitral valve prolapse. There is a condition called mitral annular disjunction that has been associated with mitral valve prolapse, where there is displacement of the annulus due to severe mitral valve prolapse, which you can see in this image, or in other words, right here, the distance between the leaflet and the annulus. And this, because of this motion of the mitral annulus, there have been cases of a late Guillerme enhancement or scarring in the papillary muscle or the infralateral myocardium, which has been associated with sudden cardiac death. So going into a little bit of detail on this subject, so since this patient has history of mitral valve prolapse, we know that patients that have mitral valve annular disjunction, this is Starling curling motion, can have a regional LV stretch, which leads to the scarring, which has been associated with ventricular arrhythmia. The distance of more than 8.5 mm has been associated with higher risk. Almost the risk that has been so far given to us is 1 in 10 patients with ventricular arrhythmias once mitral annular disjunction is present. Furthermore, if we look at overall features of mitral valve prolapse, these patients can also have cardiomyopathy. They are actually, they share the genetic substrate with patients similar to the patients with cardiomyopathy genes. So they have all these genetic substrates that can dilate the myocardium. At the same time, they also have arrhythmic risk from the mitral annular disjunction, which has been shown here due to the scar. So patients with mitral valve prolapse have these double hit that can be possible. Now, the other thing is, if we look at the MR evaluation, cardiac MRI can be very useful. We can calculate the exact regurgitant fraction in a case of a mitral regurgitation on cardiac MRI. And why this is important is because there are several studies now that show that patients, particularly with the primary MR that has been associated with mitral valve prolapse, agreement between CMR and echo criteria have been suboptimal. So we do very well when we look at the severe MR. We do very well when we look at the mild MR on echo. But in between, when it comes to non-severe MR, I'm not sure if the correlation is 1-to-1 between echo as well as CMR. In fact, if we look at the prognosis, which one to trust out of echo and CMR, CMR has been associated with a very co-linear relationship with outcomes, and hence we think that it is the CMR that we need to trust when it comes to outcome for mitral regurgitation, and hence perhaps the severity of mitral regurgitation. So I guess there are multiple papers to show how CMR has been very reproducible and quantify mitral regurgitation with accuracy in patients with primary MR particularly, and also in patients with multiple jets or eccentric jets. So this is so far the criteria for use of CMR in patients with mitral regurgitation when they have eccentric jet, multiple jets, or when it doesn't make sense, or when you want to evaluate their overall structural status of the heart, you would use cardiac MRI. Finally, last but not the least is the CAD evaluation by cardiac MRI, and we all know that this can be quite useful. MRI has been one of the sensitive and specific tools. This is a patient with a severe triple vessel disease, and you can see the perfusion defect in almost all the cardiac areas, sparing the lateral wall a little bit here. But this has been associated, with CAD. So nonetheless, my take-home points is patients with palpitation, structural changes in the myocardium in the main consideration.
Now we invite Dr. Pooja Vyas for her talk. Dr. Pooja is professor in cardiology at UN Mehta Institute. Dr. Pooja, he'll be speaking on role of CT angiography is safe and reliable option to rule out coronary artery disease.
Good noon all. So much Kamal sir for giving this opportunity. And can Dr. Purvi listen me? Can she hear me? I don't know. She's my senior and no way I can debate with her. Still I will try to prove my point here that why CT angiography is a safe and reliable option to rule out CAD as one of the commonest cause of sudden cardiac death in Indian women. So if we go through history again, she is 42-year-old female, having history of palpitation, having history of diabetes, dyslipidemia, and recent stress as risk factors, and strong family history of sudden cardiac death in elder sister and mothers in their 50s. ECG is showing non-specific STT changes. Echo is not showing any RWMA, and LVEF is normal with grade 1 MVP. She had past history of vasovagal syncope 2 years back, and 48 hours Holter is showing 3% of VPC burden without any pause. What we are worried about here is either life-threatening arrhythmia or life-threatening CAD. And why I'm more worried about life-threatening CAD is the same slide as Dr. Purvi showed, that 75% of SCD cases, sudden cardiac death cases, are due to coronary heart disease. So coronary heart disease is responsible for 75% of the cases. In rest of the 15 cases, cardiomyopathies are responsible, and 2% of the cases, inherited arrhythmias are responsible, and 5% of the cases, valvular heart diseases are responsible. And I straightway can rule out cardiomyopathies and valvular heart disease in here, because echo which was given to me was done by Dr. Kamal Sharma sir. And that was not showing any cardiomyopathies. So hypertrophic cardiomyopathy, non-ischemic dilated cardiomyopathy, and ARVC were ruled out, and significant valvular heart diseases were also ruled out in this case. And if we see in this image, as the age of SCD onset increases, as the age of the patient increases, the most common etiology of SCD is shifts from cardiomyopathy and arrhythmia towards coronary heart disease and valvular heart disease. That's why I'm more worried about coronary heart disease here. Can it be silent ischemia? Patient is diabetic, and the risk of silent ischemia is particularly high in those patients. Again, the prevalence of silent CAD among diabetic subjects observed in major studies varies from 16 to 46%. And there are also predictors of silent CAD in diabetic patient, and the most common predictor is women. And usually women complain less of a chest pain and less of typical symptoms of acute coronary syndrome, especially diabetic women. And also these are the patients who have worst clinical outcomes also. Other predictor, a very strong predictor for having silent MI or silent CAD is a positive family history of coronary artery disease. So if there is a positive family history of CAD, then even though patient doesn't have any symptoms, even though patient doesn't have any past history of cardiovascular disease, and even though patient has normal ECG and normal echo, they are at risk of developing silent CAD. And other classical risk factor for ischemic heart disease, they are also associated with silent CAD in patients with diabetes type 2. What's the scope of the problem globally? Every minute, one woman dies due to cardiovascular disease in US. And even in India, these patients, they have worst clinical outcome as compared to men. And these patients with CAD, like females with CAD, they have higher prevalence of risk factors like hypertension, diabetes, obesity, and dyslipidemia. Which are the risk factors for CAD present in our case? One is age. It is said that women have an advantage of 10 years over men in risk for CAD, but unfortunately certain risk factors like smoking, diabetes, and premature menopause, it nullifies this difference. And family history is a very substantial risk factor. And at least when your sister has a history of MI or sudden cardiac death, when the age of the patient is less than 55, then they put you at 12-fold higher risk of having CAD as compared to, like if the brothers have, they will be at 6-fold higher risk, and if there is history of CAD and parents, then it will be 3-fold higher. But it is 12-fold higher if you have a sister who had history of sudden cardiac death at the age of less than 55. Next is diabetes. She is diabetic, our patient is diabetic, and it is the strongest risk factor for CAD in women as compared to men. And in Interheart study also, it confirmed that there is a strong association between diabetes and myocardial infarction among women compared with men. And women with diabetes, they have higher adjusted hazard ratio for fatal CAD. That hazard ratio is 14.7 as compared to diabetes with men, they will have hazard ratio of 3.7 only. Even in meta-analysis, it was found that the relative risk for cardiovascular disease was 44% greater in women with diabetes than similarly affected men. So I'm concerned that this patient might have CAD. Again, patient has dyslipidemia, and among women, dyslipidemia has the highest population attributable risk at 47% compared with other non-risk factor for CVD. And also this patient is going through recent stress also, which is a novel risk factor for CAD. Psychosocial factors are considered as a novel risk factors. And now I'll prove that why CT coronary angiography. Why will I think about it? CT coronary angiography has good diagnostic accuracy. Its sensitivity ranges from 85% to 99%, with specificity between 64 to 92% for detecting significant coronary stenosis. This image, it shows the ranges of clinical likelihood of coronary artery disease. Here, if you can see that this red line, it represents the test ability to rule in the disease, and while the green line, it represents the test ability to rule out the disease. Everybody can see that with CT coronary angiography, the green line represents that the CT coronary angiography has the highest ruling out power for significant coronary artery disease. When we detect any test, we look for likelihood ratio, and it says about the ability of a test to correctly classify the patients. And for CT coronary angiography, the positive likelihood is 4.44, which is quite comparable to positive likelihood of stress CMR, which is 4.54. And if we look carefully, the negative likelihood ratio is 0.04 with CCTA. So it does say that when your test is negative, there are lowest chances that patient will have CAD. It has the maximum ruling out power. If we compare diagnostic performance of CT coronary angiography with exercise ECG and SPECT, CT angio showed better diagnostic performance for diagnosis of CAD compared to exercise ECG and SPECT, and also it reliably excluded obstructive CAD with post-test probability of below 15% in patient with a pre-test probability up to 74%. Apart from diagnosis, it also has prognostic value. So if you find on CTCA that there is no CAD, then patient will have a very low risk of MACE up to 5 years. It is less than 0.2%. And if there is non-obstructive CAD or obstructive CAD, then there will be 3 and 6-fold increased risk for future MACE rate over 5 years. Prognostic value of CT coronary angiography in diabetic patient. It can provide long-term prognostic information in patients with diabetes with suspected coronary artery disease, showing that excellent prognosis when there is no CAD at long term, and it also allows risk stratification when CAD is present. Now the question is, we can do anatomical test very well with CT coronary angiography, but what about, is it possible to do physiological testing with CT? Then answer is yes. CT FFR is the modality, and everybody knows that FFR is the proven gold standard for identifying functionally significant coronary artery disease. So CT FFR is computational fluid dynamics based measure. Now it is being done with AI deep learning methods. It does not require any additional radiation, does not require additional medications, and there is no need to change in imaging protocol as well. Here we can see that on the left side, so on the left side, this is an image of anatomical testing, and on the right side, this is an image of anatomical and functional testing, where we can see there is functionally significant stenosis in proximal LAD with distal mid LAD FFR of 0.7 and diagonal FFR of 0.74, which is significant. When we compare discriminative ability of imaging modalities for detection of significant CAD, this is ROC curve, and which demonstrates that highest diagnostic accuracy was found with CT FFR. So when we combine CT coronary angiography with CT FFR, there is highest diagnostic accuracy with area under the curve of 0.95. It also provides us information about long-term CV risk and prognosis. In this image, we can see that event rate is quite less in patients with normal FFR as compared to patients with abnormal FFR. Whenever there is a pressure gradient across a significant stenosis, it induces force imbalance locally, and it leads to decrease in FFR distally, it leads to increase in the difference of FFR, it leads to increase in the wall shear stress and increase in the axial plaque stress. So these are the things that if there is low FFR, if the difference between FFR is higher, if there is high wall shear stress of more than 154 dynes per centimeter square, if there is high axial plaque stress of more than 1,600 dynes per centimeter square, they are considered as adverse hemodynamic characteristics. So we can identify those cases on CT FFR. Next is CT perfusion. Goal of CT perfusion is to combine anatomical and physiological testing, and it typically involves two scans. One is resting scan and another is a stress scan. Rest scan does CT coronary angiography, and it does myocardial perfusion at rest, and in stress scan, vasodilator stress testing, and we can look for inducible ischemia. Here we can see that There is a lesion, CTO is there in mid-LAD, and there are collaterals coming from LCX, and at rest, there was no inducible ischemia. There was no ischemia at rest, and on stress, we can see inducible ischemia in RCA territory. When we compare the CT perfusion with other tests, in Core 320 multi-center study, it was found that it is better than SPECT for more than or equal to 50% of the stenosis on conventional angiography, and accuracy is equivalent to stress CMR for significant CAD. Identification of non-obstructive plaque is an important advantage of CT angiography that is missed by ischemia-based imaging assessment. So CT-based plaque evaluation can be a substitute for IVUS, intravascular imaging. Software makes it possible to quantify total plaque volume and assess the burden of the different plaque types, including calcific, non-calcific, and low attenuated plaque. There are certain coronary atherosclerotic plaque features which are associated with increased vulnerability. Those are positive remodeling, low attenuation plaque, and spotty calcification, napkin ring signs. So there are certain features that can pick up plaques with increased vulnerability. In PROMISE trial also, it was found there was significant association between high-risk plaque and adverse events, even if patients did not have significant coronary artery stenosis. Due to time limit, I'll skip this slide. And there are certain scores available which combines anatomical features and plaque characterization, and that can reflect the coronary atherosclerotic burden. And in suspected CAD patients, if your score is more than 5 without any obstructive stenosis, you have similar hard cardiac event-free survival compared to those patients with obstructive stenosis. Next question is, can we even identify patients before development of vulnerable plaques? So answer is yes. We can image perivascular inflammation. We can take that information. If the perivascular fat has attenuation of more than -70, then it is considered as inflamed perivascular fat. And if it has attenuation of less than 70, then it is non-inflamed plaque. So inflammation in this perivascular fat can identify vulnerable patients even before the development of vulnerable plaques. So it has a preventive role. What are the recent guideline recommendation for CT coronary angiography? It is class 1 recommendation for patient with suspected chronic coronary syndrome with low to moderate risk of pre-test likelihood of obstructive CAD. And CCTA is a class 1 recommendation to diagnose obstructive CAD and to estimate risk of MACE. And again, it is class 1 recommendation in those cases with moderate pre-test probability of obstructive CAD when other non-invasive test is non-diagnostic. Due to advancement in technology, we have now scanners like wide detector scanners available in the market, which has high spatial resolution, which has more Z-axis coverage and higher contrast resolution. So image acquisition is possible in less than 1 second for CT coronary angiography. So now heart rate is not a problem, and as image acquisition is possible in less than 1 second, there will be reduced radiation dose of even less than 1 millisievert and reduced contrast dose of even less than 50 to 60 ml. So in conclusion, I think that if not now, in future, cardiac CT will serve as one-stop shop for evaluation of coronary artery disease because it is an excellent anatomical test with more than 95% of negative predictive value. Novel methods like CT perfusion and CT FFR, they have unique way of complementing CT CA with physiological information and other information like plaque morphology and burden, and CT fat and attenuated index. It provides long-term prognostic information. Nowadays, use of AI tool is expanding rapidly, which will lead to increased accuracy in diagnosis, prognosis, and improved patient care. Whatever I say, but ultimately, local availability and site expertise will dictate the use. Thank you.
Dr. Pooja, join us on the stage, and session is open for a couple of minutes of discussion. Over to chairperson and moderators.
Hello. That was very intense debate, and coming from a radiologist community, it was good to see cardiologists promoting MRI and CT for me. So that was a fresh view. So what I personally feel is definitely cardiac MRI is one-stop shop, but CT CAG is the nearest shop and reasonably reliable shop, that is local vendor. So everything comes down to your local practices, local availability, local skills, and radiologist skill and money. This is what I think. So CT CAG in an Indian scenario being available at most of the places, and cardiologists and radiologists, they are well versed with how to read CT CAG, would be, I think, first modality in any patient, and maybe in this patient also. But again, having said that, structurally, if we want to look at heart, cardiac MRI is the best modality. For example, in this patient, we are suspecting, if we are suspecting HCM and MAD, that is mitral annulus disjunction, so there is no other modality than cardiac MRI to have a good look and holistic look. This is what I feel.
Purvi, could you hear Pooja's talk? Dr. Purvi? Any other comments from the panel?
I have a question. Hi, Dr. Pooja. Since Dr. Purvi can't hear, that's true. As a physician, this is a very common thing for us in OPD, especially I'm a female physician, right? So females do come with symptoms of angina, but usually they are dismissed as very casual symptoms or functional or basically emotionally related symptoms, and they are misinterpreted or misdiagnosed. Especially in females, this happens, and it's very common. Even sometimes by us as being females, it is missed. So investigations comes later on, but on the initial phases in OPD level, how can we just try to diagnose and then we further recommend them any investigations also?
That is very correct that females, they present with atypical symptoms, and also that they tend to have false positive exercise stress test. So they are likely to have false positive exercise stress test, and then we subject them to angiography, and then we find out that angiography is normal sometimes, and sometimes we miss also. Yeah. So that is the reason here we can go for CT coronary angiography. So at least we can rule out that there is no CAD in this patient. In many of the studies, it has been reported that the patients, usually females, they come with atypical symptoms. They are difficult to diagnose also. Sometimes this changes in ECG, they are considered as normal, and there was delay in diagnosis, and that is the reason why they have poor prognosis also. So we should be vigilant about that, and we should rather do over-diagnosis, under-diagnosis in females.
Pooja, a question. Pooja, here.
One thing.
Why not go for routine angiogram, which is a gold standard, rather than go for CT angiogram? I mean, ultimately, if there is anything, we will need to do an angiogram and then do plasty or whatever is needed. So we are going to inject dye in both the cases, right? If something comes out on CT angio, we're ultimately going to need
Are you saying
angiogram
like,
again.
But as we are
So I
talking
do-
about non-invasive tests, I think this will be the first test for ruling out.
But then why put the patient for both the things? Why inject dye twice? If you are going to perform CT angio, right? You are going
Yes,
to inject
yes.
dye, and if something comes out, you are going to need
But here,
angiogram
it
again.
depends on pre-test probability of having obstructive CAD. If the patient
Exactly.
falls in the category of between 5 to 20% of having pre-test, 5 to 50% of having pre-test probability of having obstructive CAD, then first test would be non-invasive test. If there is high probability
Yeah, but
of having CAD, high pre-test probability, then we should subject them for invasive coronary angiogram only.
Exactly.
CT-CAG is basically a gatekeeper to decide which patient should go in invasive and which patient should not go in invasive, right? So the probability, I said, is low or intermediate patient who is asymptomatic,
If you can just
then
mute
I
the
would
people
prefer
from
doing
stage, then maybe I
CT-CAG
can
rather
you
than
guys
cath
better,
angio.
because there's a
And
lot
plus-
of echoing from them.
Can I ask you? Dr. Puja? May I? So, wonderful exposition. So how much is the learning curve for knowing fat attenuation index and perivascular inflammation? It's an innuendo to the plaque inflammation, which is a very important metrics, and world is talking about it. So somebody is doing a routine CT angio. Is he well versed
Again, I don't hear
to
anything
pick
now.
up fat attenuation FAI you showed in your slide? And also, how can we combine FFR, CT hybrid thing so that we have a holistic information and we save this invasive angiogram later on in women?
Right now, I think CT FFR is available, but it is at the available of cost of 80,000 rupees per CT FFR, so it is not, I think, an option for us. But in future, when the cost comes down, I think that the invasive angiogram will decrease significantly.
About FFR, FAI detection, like are they well versed or is just a theoretical thing? A fat attenuation index you showed in your slide, which is an innuendo for perivascular inflammation or intraplaque inflammation. It's an indirect innuendo to it.
Yeah, you're talking about CT FAI?
FAI.
Yeah, but it is in developing state right now. So I don't think that those softwares are widely available
Okay,
or not.
should I leave, or is this, do you guys want me to stay longer? I cannot hear anything, I'm so sorry.
Okay, Purvi, thank you. You can answer. Thank you. Can you hear me?
I'm not aware that whether this CT FAI softwares are available in India or not. But still, there are not more
but
studies
ma'am,
available.
the plaque vulnerability is whole thing in women,
Yes,
and
it is the
even
whole thing.
just
Even
10,
if you have
20%.
normal angiogram, if you have vulnerable plaques,
Absolutely.
yes,
Absolutely.
we all have
Menopause
seen
and,
these kind of cases with having normal angiogram 2 months before, and now patient presenting with ACS.
and had a history of SCD
Yes.
with normal angiogram. There's so many
Yes,
papers. So that's where this is
Yes,
very
yes.
intriguing. I hope we have this learning curve and we understand that.
Yes,
Thank
yes.
you.
Thank you so much. I think this is the end of the first session, first bout. Thank you so much, all chairpersons, chairwomen. And we are proud that all of you are taking care of this session so well. Narendra Modi sir and Dr. Kamal Sharma, these are the two people who have paid a lot of attention to this kind of sessions. So we are thankful to Kamal bhai, you also. Now we will go to, there is a request, actually we are going to have a lot of students from medical college. So everybody who is sitting at the back, please come forward. Because we'll be getting a lot of
So there is
students
a
now.
quiz. There is a
So they
quiz
are
for
requested
everyone.
to come forward,
This is
please.
the question. Which modality has best sensitivity to assess ischemia in women? So the questions are going to be about the topic, and this is probably my way of communicating the take-home message. This is the quiz. You can scan on your phone, Memento. That's where it's going to come.
Again, a request for those
Quiz, can we have the
delegates,
quiz
they
now?
can come forward. This is the quiz. Which modality has best sensitivity to assess ischemia in women? TMT, CT angio, CV, MRI, PET. Now
You
we'll
can
go
scan. You can scan this.
to the
In the meanwhile, we can, as the quiz is happening, we'll invite the
We'll,
second chairperson.
we'll start with the second bout. Here, we would like to invite Dr. Prashant Advani, Dr. Dhaval Doshi, Dr. Krishna Kumar Goel, Dr. Bhagirath Bhai, Ketan Shah, Dr. Komal Shah, Dr. Kinnari Gupta, Dr. Mittal Prajapati. Kindly introduce the speaker. On the blue side.
CT angio, 17 people reported, and we'll also get the prizes. Can we move? This is the leaderboard. Who's the winner? These are the 11 people. Tom, whosoever is Tom, please come and collect your prize. Tom, whosoever is logged in as Tom, can collect this prize.